First of all, I would like to introduce myself. My name is Professor Ahmad طنطاوى. I'm a professor of otorhinolaryngology, Faculty of Medicine, Alexandria University, and my current position now is the head of the department. Today I will speak about surgical anatomy of the larynx. Why we have to study the surgical anatomy of the larynx before even studying the diseases of the pharynx, because these two organs, the larynx and the pharynx, are very close to each other anatomically, and there is a lot of diseases which are common between the two organs, especially in cases of tumors and cancers, which can easily spread from the larynx to the pharynx and from the pharynx to the larynx. And that's why we have to understand the anatomy of the larynx very well before even studying the pharynx. So first of all, the larynx is a unique organ. Why I'm saying that the larynx is a unique organ? Because it is formed of several components. In the larynx, you will find cartilages, you will find ligaments, you will find membranes, you will find muscles, and you will find joints. So I don't think that is an organ in the body that has all these structures, and at the same time it's got a sensory supply and a motor supply. What does this mean? That it has sensation and at the same time it moves. So larynx is very unique in its structure. And this will answer a question that all over the world there were successes in transplantation, like liver transplant, heart transplant, kidney transplant, and up till now all the attempts to perform laryngeal transplantation failed with no success. This explains that the larynx is a unique structure, very complicated, and that's why even transplantation is not successful all over the world. So let's start by looking at the slide over here, the boxes that we have in different colors. Before starting this, I would like also to just give a hint of the functions of the larynx. The larynx mainly is the organ of voice or speech. We speak with the larynx, and that's why if the larynx is taken out or there is a total laryngectomy, the patient loses his voice unless we use an artificial device or another way of speech. The second function is respiration. It's the organ where air passes from the oropharynx into the larynx, then into the trachea and bronchi. And the third function is protection against aspiration, where there is a certain mechanism that the larynx can protect any fluid or saliva or even water that can passes into the larynx and preventing from any aspiration and complicated aspiration pneumonia. So these are the three functions of the larynx: speech, respiration, and protection. Let's move to the first slide, the photo on the left side. We have boxes in different colors. We have the box in blue color, and then the box here in the violet color, and then we have 4 boxes in green color. So the violet color box represents the oral cavity. The blue box represents the nasal cavity. If we go posterior from the nasal cavity, we find the first green box, which is the nasopharynx. If we go posterior from the violet box, we will get the second green box, which is the oropharynx. And then oropharynx is continued inferiorly as the hypopharynx, and then it will be continued as the esophagus. So the 4 green boxes represents the pharynx, nasopharynx, oropharynx, hypopharynx, and esophagus. Now we come to the red box. This represents the airway or the larynx, where the larynx is continued below as the trachea. So in the neck, you will find that the air column, which is the larynx, is anterior to the fourth column, which is the esophagus. Both are back to back, and the larynx is anterior where the esophagus is posterior. Let's have a look about the cartilage of the larynx. We have the cartilages of the larynx are either single or paired. What means single or paired? Only the cartilage is only one cartilage, or we have two cartilages of another kind. So the first one is the thyroid cartilage. Here we have the thyroid cartilage. This is a single cartilage. It is a flat cartilage. Flat means that what we see anterior, we'll get it posterior. This is the anterior view, and this is the posterior view. The thyroid cartilage is formed of two lamella. The one lamella is over here, and the other lamella was over here. This is the right, and that's the left. And then we have the superior surface. We have an inferior surface, and we have two parts that's coming up from the one coming from the superior surface and one coming from the inferior surface. These are the cornea. This is the superior cornea of the thyroid cartilage, and that's the inferior cornea of the thyroid cartilage. Along the superior surface of the thyroid cartilage, we will have an angle. This angle is right angled in males. What's meant by right angle? Right angle, the angle is right. So when the angle of the two lamellas are right angle, that means we will have a protrusion. This protrusion, it's what we call Adam's apple or laryngeal prominence. So it is prominent in males because the two lamellas are right angled. In females, the angle is widened, so it becomes obtuse. When you widen the angle, you will have the protrusion will not be apparent. So females do not have Adam's apple or laryngeal prominence because the angle between the lamellas are obtuse. So this is the laryngeal angle over here between the two lamellas, which we call it the laryngeal prominence. If we have a look at the posterior aspects of the thyroid cartilage, it's exactly the same like the anterior, but we can see here the superior cornea and the inferior cornea, how it is related to the lamella. This is the lateral view, where we can see only one lamella, and this is the superior cornea, inferior cornea, superior surface of the thyroid cartilage. This is the laryngeal prominence, and that's the inferior surface. Okay, this is all what we need to know about the thyroid cartilage. Let's move to the other cartilage, the second cartilage, which is the cricoid cartilage. Cricoid cartilage has got a very specific structure, which it is in the form of a ring. So if we say a ring, that means that it has a diameter. So this is the cricoid cartilage. It is in the form exactly like the ring, but this is the anterior part, which is narrow, and this is called the arch of the cricoid cartilage. That's the posterior part, which is wide, and this is called the lamina of the cricoid cartilage. So if you look at the larynx and you find the cricoid cartilage very wide, that means that you're looking from the posterior view, because this is the lamina of the cricoid. But if you look at the larynx and you find the cricoid cartilage is narrow, this is the arch, so this is, you're looking from the anterior aspect of the larynx. Here, this is the cricoid, as I said, in the form of the ring. This is the diameter. This diameter is very important because any affection of this diameter, I mean that if it is narrowed by any reason, either a congenital anomaly or an inflammatory disorder or a neoplasm that will affect the diameter of this cricoid cartilage, this will lead to narrowing of this area, and definitely the patient will get difficulty in breathing, which we call it stridor. Stridor is a definition where you have a difficult, noisy breathing due to partial obstruction of the upper airway, and we have to differentiate between stridor and dyspnea. This is very important. So anything affecting the diameter of the cricoid cartilage will affect the respiration of the patient. There are two important facets that are present on the cricoid cartilage, one on the lateral aspect over here, and once I say a facet, that means there is a joint. So we have to just see that this is the inferior cornea of the thyroid cartilage, and this is the facet on the lateral aspect of the cricoid cartilage. Here, the inferior cornea will be joined to this facet to form the first joint, which is the cricothyroid joint. We'll see it in the other slides, very well demonstrated. On the superior surface of the cricoid cartilage, there are two other facets, one right and one left, and these facets where two other cartilages will sit on the superior surface. These are the arytenoids, will sit on these facets to form the second joint, which is the cricoarytenoid joint. So let's have a look at this slide just to demonstrate. This is the thyroid cartilage, superior surface. This is the laryngeal prominence, inferior surface of the thyroid cartilage. This is the superior cornea, and this is the inferior cornea. This is the arch of the cricoid cartilage, and this is what I'm talking about, the attachment of the inferior cornea to the facets on the lateral aspect of the cricoid cartilage, forming the cricothyroid joint. So let's move to this slide. Again, this is the cricoid arch, and this is the lateral view. This is the facet for the cricothyroid joint, and here are the two triangular shaped cartilages called the arytenoids. The arytenoids, and I'm saying arytenoids because they are paired. There is a right arytenoid and the left arytenoid. And the simple description of the arytenoid cartilage is it's triangular in shape, and once I say a triangle, the triangle has got an apex, like here. It's got a base, and at the same time has got two angles. This is an angle, and that's an angle. So this is considered to be the medial angle, and that's considered to be the lateral angle. The medial angle is called the vocal process of the arytenoid, and the lateral angle is called the muscle process of the arytenoid. So once I say the vocal process, so I expect that the vocal cord will be attached to this process, and once I say the muscle process, I expect that the muscles of the larynx are attached to this process. So the arytenoids are sitting on the superior surface of the cricoid posteriorly, forming the second joint, which is the cricoarytenoid joint. It's a very, very important joint because it's this joint has got a very great role in the mobility of the vocal cords. So these are the arytenoids. Let's have a look at the fourth cartilage, which is the epiglottis. Epiglottis is single, and this single cartilage is leaf-like, exactly like a leaf-like, has got the petiole or the stalk of the epiglottis over here, and it's got pits. Pits means small holes in the epiglottis, and at the same time the epiglottis is attached to the thyroid cartilage posteriorly below the laryngeal prominence, on the posterior aspect of the thyroid cartilage. And I'll show you in a minute where is it attached exactly. This is the attachment of the epiglottis on the thyroid cartilage posteriorly. Let's move to the previous slide. If we look at the thyroid cartilage posteriorly, this is the laryngeal prominence, and just beneath the laryngeal prominence on the posterior aspect will be attached the epiglottis, exactly over here. And as I said, that the vocal process of the arytenoid, there will be two vocal cords coming up from the vocal process. The vocal cords are like number 8 in Arabic, but it is horizontal. So these are the two vocal cords. This is the vocal process of one arytenoid, and that's the vocal process of the second arytenoid, and the two vocal cords just meet at a point which is called the anterior commissure. So the point where the two vocal cords meet together is called the anterior commissure, and here exactly would be the anterior commissure. And if we look at this slide, we will understand what I mean by the anterior commissure. Look, this is the arytenoids sitting on the cricoid cartilage where it forms the cricoarytenoid joint. That's the vocal process, and that's the other vocal process. The two vocal cords meet together at a point called the anterior commissure. Okay, let's move to this slide. Now we have a clear look about the surface anatomy of the larynx. So if we just try to do it on ourselves, I can feel here now the thyroid cartilage, and this is the laryngeal prominence. This is Adam's apple, and if I go a little bit downwards, I will feel the cricoid cartilage. It's over here. In between the cricoid and the thyroid, there would be a membrane. I just can feel it here. I'll show it in a minute. And then I can feel the first ring of trachea, and in between the first ring of trachea, and the cricoid, there is a second membrane, which is the cricothyroid membrane. So let's apply this on what we see on the slide. So this is the thyroid cartilage, and this is the cricoid cartilage, and that's the first ring of trachea. Between the thyroid and cricoid, there is a small membrane called the cricothyroid membrane. Between the cricoid and the first ring of trachea, there is a membrane called the cricotracheal membrane. If we move a little bit superiorly over here, there will be a bone. This bone anatomically is not a part of the larynx. Anatomically is not a part of the larynx, but it is called the hyoid bone. But because it is attached to the larynx, so we have to give a little hint of the hyoid bone. So we can feel the hyoid bone over here. The hyoid bone is formed of a body and two corneas over here, or lateral horns of the hyoid bone. The hyoid bone is attached to the thyroid cartilage by a membrane called the thyrohyoid membrane. This thyrohyoid membrane has got very important characteristic structure, which is a small hole on each side, or an aperture. This aperture permits the transmission of an artery, a vein, and a nerve from outside the larynx to inside the larynx. And when we talk about the blood supply and nerve supply, I will tell you what are the arteries and veins and what is the nerve that pass through this small aperture. Let's have a look at this slide. I think now we are all can understand that this is a posterior view of the larynx, because the cricoid here is very broad. So this is the lamina of the cricoid cartilage. On the superior surface, these are the two triangular cartilages, which are the arytenoids, sitting with a facet forming the cricoarytenoid joint. And here comes the epiglottis with its attachment. This is the hyoid bone, and the hyoid bone is attached to the thyroid cartilage by the thyrohyoid membrane. And these are the aperture on both sides for transmission of the vessels and nerve, which I told you about. And definitely this is the thyroid cartilage, the lamina and the other lamina, with the superior cornea and inferior cornea. If we move to this slide, the green color slide, I don't think there is anything new. It's very, now I think you can understand. We are looking at the lateral aspect of the larynx. We had to remove one lamina so that we can see what we are seeing now. This is the cricoid cartilage, that's the posterior view, and that's the anterior view, because this is the arch, which is narrow, and this is the lamina, which is very broad. On the top, there is arytenoid, triangular in shape. This is the muscle process, which is the lateral process, and that's the vocal process, which is the medial process, and this is the vocal cord coming out from the vocal process. And these are the thyrohyoid membrane, the aperture, and between the cricoid and the trachea, this is the cricotracheal membrane. So I think now we can fully understand the framework or the structure of the larynx and the cartilages of the larynx. I don't think that there is anything new that I can add in this slide, but it's the same surface anatomy that I was talking about, and I'm sure that it's now clear the anatomy of the larynx. So let's move now to the endoscopic view. Our problem in otolaryngology that we are working in narrow spaces. I mean, the larynx is a narrow space, the ear is a narrow space, and the nose is a narrow space. So our examination is always endoscopically, using an endoscope. The only space that we work with ample of space is when we perform neck surgery or head and neck surgery, where we perform the thyroids, parotids, and we open the neck. We can have a bigger space than the larynx, ear, and nose. What I explained before is not what you see on the patient, because to see the skeleton of the larynx, you have to open the neck, skeletonize, remove the muscles, and see the cartilages as I explained. But what we see in clinically is the endoscopic view of the larynx. This is the endoscopic view of the larynx, and what is here is the epiglottis, and these are the two arytenoids over here, And definitely, if these are the arytenoids, then these are the two vocal processes. And we can see these two white structures as letter 8, as I said before. These are the vocal cords. This is the right vocal cords, and that's the left vocal cord. Both are attached together in the anterior commissure. So now these cords are adducted together in an adduction position. And adduction position means that the cords are very close to each other. And I will tell you about the movements of the vocal cord when we talk about the muscles. The arytenoid is over here, and that's the epiglottis. So there is a fold, mucosal fold on the right side, mucosal fold on the left side. In the mucosal fold, which is called the aryepiglottic fold, there are two other cartilages, which are the cuneiform and corniculate. The cuneiform, we have right cuneiform, left cuneiform, corniculate, right corniculate, left corniculate in the aryepiglottic fold, and these are rudimentary cartilages without any function. So to sum up the cartilages, we have 3 single thyroid cricoid epiglottis, and we have 3 paired arytenoids, cuneiform and corniculate. Let's have a quick hint about the muscles of the larynx. We can divide the muscles of the larynx according either to the function or to the position. So we have muscles which are located inside the larynx, and these are what we call intrinsic muscles of the larynx. And we have muscles located outside the larynx, and these are called extrinsic muscles of the larynx. The extrinsic muscles of the larynx is only one muscle, which is the cricothyroid muscle. It's over here, we can see it. This is the cricothyroid muscle between the thyroid cartilage and the cricoid, and this muscle is the cricothyroid muscle. This is the only extrinsic muscle of the larynx. The intrinsic muscles, we have 5 intrinsic muscles. Number 1, this is the posterior cricoarytenoid muscle on both sides. This is the lateral cricoarytenoid muscle, but the right one is apparent, the left we cannot see in the slide. And then we have an X-shaped muscle, which is the oblique arytenoid muscle, and a sheet of muscle lying underneath this X-shaped muscle, which is the transverse arytenoid muscle. And then finally we have a muscle in the vocal cord itself, which is called the vocalis muscle. So to sum up muscles, extrinsic, only one muscle is the cricothyroid muscle, which is over here. Extrinsic, only one muscle, which is the cricothyroid muscle. Intrinsic, there are 5 muscles: the posterior cricoarytenoid, lateral cricoarytenoid, transverse arytenoid, oblique arytenoid, and the vocalis muscle. If we divide the muscles according to functions, so functions, we do have 3 functions or 3 mobilities. Either muscles that get the cords together, which these are called the adductors. You add the cords together, or muscles that separate the cords from each other, and this is called abductors. And there are muscles that stretches the vocal cord or relaxes the vocal cord, and these are called the tensors. So what do you think? What muscles are more important? Muscles that open the vocal cord in an abduction position, or muscles that closes the vocal cord in an adduction position? Yes, definitely that muscles that open the vocal cord are more important, because if the cords are in an adducted position, the patient will have no space for respiration, and the patient will go through an attack of stridor. Depending on the degree of closure, the degree of stridor will be apparent on the patient. So the muscle that opens the vocal cord is called the posterior cricoarytenoid muscle. Posterior cricoarytenoid muscle, and this is the only abductor muscle of the vocal cord that opens the cord. Muscles that closes the vocal cord are other muscles: the lateral cricoarytenoid, the transverse, the oblique arytenoid. Now we come to the function of the extrinsic muscle, which is the cricothyroid muscle. This is a tensor. This is the muscle which stretches or relaxes the vocal cord together with the vocalis muscle. This slide actually will show us, if we draw a line at the level of the vocal cord over here. over here. Any structure above the level of the true vocal cord is called supraglottic. From the true vocal cord to the 1 centimeter below, this is the glottic area. And from 1 centimeter below to the lower border of the cricoid cartilage, this is the subglottic area. So we can divide the larynx into 3 spaces: the supraglottic space, and this is the supraglottic larynx, or the glottic area, or the subglottic area. Why are we dividing the larynx in these 3 areas? Because these areas has different embryological origin, and thus carcinoma of the supraglottic area will behave completely different than carcinoma of the glottic area, and will behave completely different than carcinoma of the subglottic area, and prognosis will be different also in these 3 areas, and at the same time the management will be different in same areas. If the cancer spread from one area to another, this is called transglottic carcinoma. Let's have a structure about the vocal cord. Vocal cord, it's not a cord, it's a fold. Actually, it's a fold. A fold means that there are several layers, and these layers are just present from the medial aspect of the cord to the lateral aspect. If we start from the medial aspect of the cord, the first layer will be the epithelium, and this is the squamous epithelium, it's over here, and then followed by the lamina propria. Lamina propria, as we remember from histology, is divided into 3 layers: superficial layer, deep, and intermediate layer. These 3 layers forms the lamina propria. The superficial layer of the lamina propria is called the rhinic space. Rhinic space is the superficial layer of the lamina propria. Then if we move a little bit more medial, lateral, we will have the vocal ligament, and then we will get the vocalis muscle. So from medial to lateral, epithelium, squamous epithelium, lamina propria, vocal ligament, and vocalis muscle. This is the structure of the vocal fold or the cord. Nerve supply, as I said before, that the larynx has got sensory supply and motor supply. The main nerve supplying the larynx is the vagus nerve, which is the 10th cranial nerve. The vagus nerve, as it comes down from the jugular bulb, it will give us the first branch, which is the superior laryngeal nerve, which is over here. The superior laryngeal nerve will divide into 2 branches. One internal, and this internal branch will pass through the aperture. So this is the first structure that passes through the aperture in the thyrohyoid membrane, and this is the internal branch of the superior laryngeal nerve, and this is sensory. It supplies or gives sensation to all the larynx above the level of the vocal cord. The second branch of the superior laryngeal nerve is the external branch. The external branch is motor, and it supplies only one muscle, which is the cricothyroid muscle. So the only muscle supplied by the superior laryngeal nerve is the cricothyroid muscle. Now we come to the second branch of the vagus, which is the recurrent. Why we call it the recurrent? Because it descends down into the mediastinum and then turns around to pass in the groove between the trachea and esophagus to enter into the larynx. Before it enters into the larynx, it divides into 2 nerves. One sensory, where it supplies the larynx below the level of the vocal cord, and one motor, which supplies all muscles, all intrinsic muscles of the larynx. So we will remain with one area, didn't get any sensory supply, which is the glottic area or the vocal cords. The vocal cords get its sensory supply from anastomosis between the supraglottic area and the subglottic area, anastomosis between the internal branch of the superior laryngeal nerve and the sensory branch of the recurrent laryngeal nerve. The vocal cords get anastomosis from these 2 nerves, and this is called anastomosis of Galen. So to sum up the nerve supply of the larynx, we can just say in 2 words: sensory supply of the larynx above the cords is coming from the internal branch of the superior laryngeal nerve. Sensory supply below the level of the vocal cord is coming from the sensory branch of the recurrent, and the area of the vocal cords, anastomosis between both. Motor supply, all muscles of the larynx are supplied by the recurrent except one muscle, which is the cricothyroid muscle, supplied by the external branch of the superior laryngeal nerve. Last thing that we'll talk about is the blood supply. The blood supply of the larynx is coming from the external carotid artery. The superior part of the larynx is supplied by the superior thyroid artery, and the superior thyroid artery will give the superior laryngeal artery, which will pass through the aperture in the thyrohyoid membrane. So we said that there is a nerve, internal branch of the superior laryngeal nerve, and the artery is the laryngeal superior laryngeal artery, which is a branch of the superior thyroid, which is a branch of the carotid, and the artery is accompanied by a nerve. So the superior part of the larynx is supplied from the superior laryngeal artery. Inferior part of the larynx is supplied from the inferior thyroid artery, which supplied the lower part of the larynx. Finally, the lymphatic drainage of the larynx along the internal jugular vein. We have a group of lymph nodes. These are the superior group of lymph nodes, the deep cervical lymph nodes, and then we have the middle deep cervical lymph nodes and the inferior deep cervical lymph nodes. Supraglottic area drains in the superior group of deep cervical lymph nodes, and the subglottic area drains in the inferior group of the deep cervical lymph nodes, and the glottic area has not any lymphatic. There are no lymphatics supplying the glottic area, and that's why this is the best prognosis. I hope that I just explained the anatomy of the larynx, and good luck in your lectures and in your exams. Thank you.